I will introduce one of the youngest dynamic speaker, Dr. Prasana.
Thank you, sir.
Prasana Venkatesh. He is the head of the glaucoma research services at Mahatma Eye Hospital Private Limited, Trichy, Tamil Nadu. And he has got a lot of publications, 131 articles in various peer-reviewed and PubMed journals. I think we would love to hear to him whenever he speaks.
Thank you, sir.
Please.
Thank you for the kind words and all the stalwarts of teleophthalmology in India. It's a humbling experience to speak in front of you. Thanks a lot for the opportunity, sir. Really appreciate it. And I'm going to share a few of the publications that we published. I totally agree with the seniors who spoke before me. COVID was one that really set me on the path of teleophthalmology because necessity was the mother of invention. So this was a model that we did in hospital, which we are now trying to incorporate into the 7 vision centers that we have actually started. So when COVID happened, we had this cubicle in our hospital, and just like the Marvel Infinity Stones, what we did was we connected all these gadgets in the computer because only few doctors were actually working inside this cubicle. So in this one computer, we had all the data connected with the server Cisco, and only one particular doctor used to be in, but we'll try to make sure that we interconnect this gadget. This is the article that I am quoting, which is published in 2021 in the Indian Journal of Ophthalmology, where we had the IP address assigned, and you can see here at anywhere I can access the case sheets from that particular computer. So this is a progressive glaucoma patient where you can see that I don't need to be there. Once the imaging is done, I can go and choose any choice of view that I want to. It's not like an EMR. This is called LAN, or you can also have a wireless LAN, local area network, where even I can click the desktop, I can choose the visual fields of the patient, I can choose which frame of visual field that I want to see. In LAN, in EMR, what happens is you'll have only one fundus or one visual field what they feed into the EMR. But with this particular thing, I can go and search in any choice of frame that I want to. Even you can see here, this is an optic disc pit with CSR. If I want to have a zoom, or if I want to see the OCT of the patient, I enter the MR number. I keep this data side by side, and I can just go through the exact slices of all the OCT of this particular patient to see how the peak is or how is it coming down after treatment. So we focus more on many frames. So this was what we were doing. One particular paramedical or medical person were inside, and they used to take all the data, and since everything was interconnected, we used to use AnyDesk sometimes. You can see sometimes when the doctors at home, especially during the COVID, if you install AnyDesk in your computer and AnyDesk in that particular computer that I was telling where all the machines were connected, even in hazy media where a B scan was done and fed into that computer, bilateral mature cataract, a B scan, even today I can access it from my smartphone. You can see that every slices of it has easily been accessed, as you can see in this video that is being demonstrated. Even the biometry files, if you want to choose an IOL, you are not on station today. As I told, we have 7 vision centers which are recently open. If you have a biometry there, even those files can be accessed. Even the structure function correlation in glaucoma, which is not really very much possible with an EMR because of the structure function constraints of fixed images. But with this, you can see that we focus, we zoom. I can see how much the inferior notches, superior notches, how the polar analysis loss is corresponding to the inferior and superior notch. Even the much detailed quality examination is possible. As I told you, EMR is having slight limitation compared to this LAN, which we actually innovated in our center. And even today with your smartphone, you can access these files. As you can see here, beautifully accessing one of the files here, a coloboma patient. There is very subtle fluid in the subretinal fluid. Even those subtle fluids, you can see, I can go to the Spectralis mission, see at which layer I can choose a layer that I want to. I think these will help us give qualitative treatment in a cost-effective way for the rural patients, because we are all here together to serve the people, and we all are talking about vision centers today. So we have different imaging modalities in different vision centers. We want to make sure that we examine every section of that patient's fundus, OCT, or whatever data that we arrive. We want to make sure we deliver the best quality to the patient in a very cost-effective way. So this, my dear friends, will serve us in a smart evolution of teleophthalmology. Again, another article of mine in December 2022. And recently, we are also venturing into the metaverse. I'm quite fond of it. I think we can make case sheets of patients in the metaverse, and we can attach the patients their own case sheet, be it the neuro-ophthalmology on the left, or in augmented reality, the patient's own eyeball can be constructed, where the patients can be given their own case sheet at the end of the day, be it immaterial. These are all cost effective. It costs nothing actually. Basically, we have done it in an offline mode, free of cost. The app's name is IMG AR and IMG Max for Android and iPhone respectively. And also counseling. Sometimes I feel when you counsel the patients with their own images taught to me by my mentor, their conversion rate and understanding about the diseases are much better. So you can see that if there, even when we see a neuro-ophthalmology case or even an ophthalmic case, we can counsel the patients with their own case sheets that help us in understanding the concepts better. And this is again another innovation of ours in 4 dimensions, where you can use the hand as a hand tracker and examine the case sheets. This is all not the future, my dear friends. Metaverse is actually here, and we especially at our center at Mahatma Eye Hospital Trichy, we are doing some path-breaking innovations in metaverse, and these are all patient point of care innovations in an economical way. It's not that much of money as what is being projected. You can see this is a workflow. A patient comes in, you take the data. In the hospital database, we are trying to innovate a translational software by which we can get these kind of case sheets generated in no time. So COVID was actually, if it came as Thanos, we certainly made many path-breaking innovations like Iron Man and other things. These are all not a hype that we see in a Hollywood movie, which is no more a science fiction. These are all now moving towards science-based reality. Like as a very senior person, sir, told, it's never going to replace her. I totally agree with you, sir. Doctor and artificial intelligence are going to work together for a better humanity, because this is the publication that I did, sir, recently. Today it's getting the IJO Certificate of Merit Gold Award, utilizing human intelligence in artificial intelligence for detecting glaucomatous fundus images using human-in-the-loop machine learning. I, for one, believe that human will always be on top, and the machine will always be there to augment human intelligence and never replace human intelligence, because humans will always be on top. This you can see. This fundus is trained by a human. So where is the bionetting sign? Where is the vertical cupping? How is the RNFL defect? So humans will be there to train the machine. This is called human in the loop learning. There are so many algorithms. I believe in HITL, human in the loop learning, where humans will train it just like a baby. And then when we feed a fundus, that will predict not only the diagnosis, along with the diagnosis, it will also give you where are the intricate findings. Because today in AI, black box is a very limiting phenomenon. We don't know why the AI predicts the way it predicts. We want the AI to have an explainable model. That is what we are working on. Once you feed, you can see the diagnosis. So you can see not only diabetic retinopathy, again you can see even the small hemorrhages are being fed. More the data we feed into the machine, more we get an interpretation. So this is my last slide. So this is the particular flowchart that I am currently working on, where any imaging tool with our AI or AR software, within a 60-second time, can it really generate a result? And we are trying to launch an offline app regarding the same, which will be very well reproducible and be able to be used by all. And that is the final endpoint. We want the vision centers to run, because as an economic country, a developing nation, it is ultimately about delivering the patient in a very cost effective way. That's why we are trying to work 2-3 different parameters with which we can crack it. So hopefully we'll be able to do it. And thank you once again, sir. And these are some of my other publications. Predominantly I'm publishing in Indian journal and European journal as of now. So feel free to definitely Google it. And thank you once again, sir, and the whole panel
Dr. Prasana,
for the opportunity.
It's really wonderful talk.